Good afternoon. This is Jen Kovich-Bordenick with the eHealth Initiative. Welcome to our afternoon webinar. We've got an incredible webinar for you this afternoon. We're going to get started in just a minute. We have a lot of people joining right now, so we'll give them just a moment or two to get on the line with us. Hope everybody is surviving their quarantine or sheltering in place or whatever they happen to call it in your state. We've been having a little bit of fun here over the last couple weeks during this webinar series. So if you are out there, tell us what's the first thing you want to do when you get out of your quarantine. Just stick that in the chat box. Give us an idea what you are, what you're missing right now. Going to the beach. All right, Candace, we love that. Concerts. Okay. I know, I can't wait till my children go back to school. Having a steak dinner at a restaurant or going to the movies. Ooh, CrossFit gym. Family events. Someone's actually missing family events. Must not be with the family you're staying with. Hugging your grandkids. Oh, great one. Great one. Backyard grilling. All right. These are all things we miss. You're making it a little bit, I don't know, what's the opposite of being homesick? Seeing your grown kids. Oh, that's so sweet. These are great. These are really wonderful. It's nice to see some positive thoughts here today. All right, we still have a lot of folks joining, so we're going to give it just one more minute while people are joining. How about one other quick question? If you could be quarantined with anybody right now, dead or alive, who would you want to be in quarantine with? Love to see that. Drew Schiller, oh my goodness.
Thanks, Peter.
Obama, Denzel Washington, okay. Serena, Tom Selleck, ooh, that is a blast from the past. My husband for sure. That is so sweet. Brad Pitt. How about Dr. Fauci? Definitely my dog. Oh, you guys, these are great. Wonderful. Elon Musk. We definitely have a Silicon Valley tech crowd with us here today. Rita Hayworth, okay. Aw. Massimo Bottura. Great suggestion. Okay. All right, we're going to go ahead and get started, Claudia. We've got a few housekeeping items, so we'll go through those as additional folks are joining today. Again, welcome. You want to go to the next slide there, Claudia? So again, I'm Jen Kovich-Bordenick with the eHealth Initiative and Foundation. We're delighted you could be with us here today. And we have an incredible group. I'm going to let them introduce themselves in just a moment here. Peter Rasmussen, who is the Chief Clinical Officer at Cleveland Clinic and the American Well Joint Venture, a great, great program we're going to hear about. Robert Jaron, who's a managing member of Omega Concern and an advisor to the ACC, American College of Cardiology. And also an advisory member to the AMA, American Medical Association. And finally, last but not least, one of my favorite people, Drew Schiller, who is the CEO and co-founder of Validic and a member of the CTA's Board of Industry Leaders, Vice Chair of CTA's Health and Fitness Technology Division Speaker, and also on the eHealth Initiative Board of Directors. So delighted to have you here today, Drew. Next slide. Let's go through a couple of housekeeping items before we get to introductions. If you haven't figured out by now, everybody is muted. If you'd like to ask a question, the majority of the time today is going to be spent with panel questions and answering your questions. So go ahead and get your through that Q&A box on the bottom of the screen, and we're going to get to as many as we can. If you have technical difficulties, do not put that in the Q&A box. Put it in the chat box. Again, there will be time, hopefully, for us to get to as many questions and answers, but if you put your question in the chat box, we will not get to it, so please do that. Already getting questions about slides. There are not going to be a lot of slides today, but there will be a recording of today's presentation and the slides that we do use today available for download on our resource page, and the presentation on the audio and everything should be up by tomorrow, so you can get that at ehighDC.org/resources. Next slide. For those of you who are not familiar with our mission, eHealth Initiative, we convene executives who are transforming healthcare through technology and innovation. And that's really what we've been spending the last several weeks doing as we've been all trying to get through this challenging ordeal with the COVID-19, is really convening executives around a number of different webinars and events to really talk about what's happening right now and how we can deal with this current challenge using technology and innovation. Next slide, Claudia. This is just a sampling of some of the folks who are involved with the eHealth Initiative if you don't know much about us, and you can see it's a pretty impressive and influential group. We would love to have you at the table with us as we develop programs and do research and advocacy. If you're interested, we'd love to talk to you after the program today, so feel free to reach out. Next slide. And generally, these are the areas of focus that we focus on at eHealth Initiative: transparency, interoperability, privacy, analytics. You can see there's a whole assorted group of interesting topics that we tackle each and every day at eHealth Initiative. But we have spent a lot of time the last 6 weeks, 8 weeks, next slide, Claudia, really focused on COVID-19 as they relate to these areas. So COVID-19 around interoperability and analytics. We're doing a lot of work around that right now, and also privacy. So you can see there are a number of different upcoming programs. We've got a program on May 5th around digital health in the age of COVID-19. We have one coming up on May 7th as well, looking at telepsychiatry and best practices and regulatory priorities. And I know we've also got a number of other programs coming up. I think there's one with Fitbit next week, which I don't see up here as well, and a program also coming up with the American Cancer Society in a couple of weeks. So stay tuned and keep checking our event page for these programs. We would love to have you there. If you're interested in sponsoring a program or being part of a program, just go ahead and reach out to Amy there at EHI, Amy at ehighDC.org. We would love to get you involved in our programs and talk to you about joining our initiative. Next slide. And I want to thank Drew and Validic for sponsoring this wonderful program today. eHealth Initiative is a really small nonprofit, and we wouldn't be able to do any of this programming, any of these educational programs, without support from generous groups like Validic. It's really important that we talk about remote monitoring, that we talk about different ways to use innovation and technology right now, and we're really delighted and grateful that we have organizations like Validic who are willing to do that. Next slide. So I'd love to give each of the speakers, panelists today, an opportunity to introduce themselves. So why don't we go ahead and just start with Drew? You want to kick us off?
Absolutely. Thanks, Jen, and thanks, Peter and Jaren, for joining me today. I'm super excited for the conversation. So I'm the CEO at Validic. Validic is the leader in personal health data and making sure that data that people capture in their everyday lives is brought into the healthcare system and made to be actionable. So everything from in-home monitoring devices, wearables, health apps on the phone, straight into the clinical medical record, into the clinical workflow to enable proactive care. That's what we do. And as Jen mentioned, I'm on the board of EHI, and I'm also the vice chair of the Health and Fitness Technology Board with the Consumer Technology Association, and super excited to be here and for the conversation today.
Hi.
Dr.
Yeah, this is Peter Rasmussen. Thanks for inviting me today. Currently, I split my time 50-50 between Cleveland Clinic, where I continue as a practicing neurosurgeon, and the other half of my time I'm serving as the Chief Clinical Officer for the Cleveland Clinic and American Well joint venture spinoff. I got started in telehealth about 18 years ago when I was running the stroke center at the Cleveland Clinic, and built, along with my team, the Telestroke Network. And then 6.5 years ago, the CEO at the Cleveland Clinic at that time, Toby Cosgrove, asked me to oversee digital health across the enterprise. And I did that until January of this year. And then they moved me over to the joint venture. The purpose of the joint venture, which was formed by Ido Schonberg, CEO of American Well, and Tom Mihalovic from the Cleveland Clinic, is to really energize digital health programs for both organizations, to draw on the expertise from the parent organizations, the clinical horsepower and expertise that we have at Cleveland Clinic, our technology platform that's been built over the years, which includes the Validic technology, and then also leveraging American Well relationships and the technology platform as well. Our first area of interest has been in educational second opinions to a global audience, and we're beginning a partnership with Validic and Drew at this moment around remote monitoring.
Great. And Robert.
Hey there, guys. Can you hear me?
Yeah, loud and clear.
Great. Okay, great. Perfect. Thank you. So my name is Robert Jaron. Everybody calls me by my last name. I'm not sure how that started, but it was probably over 20 years ago. I formerly served for close to 20 years as a senior director of government affairs for Qualcomm Incorporated. My area of expertise ended up becoming wireless health and life sciences. I left the company about a year ago. I went on my own. I have a number of clients, including Validic. Some of my clients include associations and other companies, and I'm glad to be here today. But, you know, a quick word to everybody that's affected by this tragedy, thinking about you, and I hope we can all come out of here as best we can. Thanks for having me.
Great, thank you. All right. Well, welcome to all of you. We're delighted to have all of you guys here today. And I just want to echo what, so I guess we'll call you Jaron. We are, of course, we know that there are a lot of folks who can't be on this call today, a lot of providers and payers and essential workers on the front lines, and we are thinking of you. We know this is a really stressful time, so if any of you are joining us, our hearts go out to you, and we thank you for all the work that you're doing on the front lines right now. So why don't we jump right into it? So each of you are really coming at this whole pandemic, I think, from really different viewpoints. And I guess I'd like to hear from each of you kind of in your own perspective, how do you think it's going? I mean, how do you think healthcare is responding to COVID-19? And are there any specific actions you've taken or you've seen other take during this time? I guess just some general thoughts and reactions here. And Dr. Rasmussen, why don't we just start with you?
Yeah, it's interesting, and you look across the country how there's been different areas that have been more or less affected by COVID-19, and fortunately in Ohio, we have been spared certainly the worst of it. Perhaps it has to do with the response from our state government. Hard to know. Maybe it just has to do with variability of the natural history of the virus and the disease itself. But we took a very proactive action toward COVID-19 at the Cleveland Clinic. We very quickly shut down elective procedures and surgeries and immediately began planning for a surge in potential hospitalization of patients. And that really had to do with training up physicians such as myself as potential ICU physicians, and really leveraging every caregiver in the organization for potential clinical role, whether they were non-clinical before or after. In addition, we made plans to convert 2 of our administrative office buildings into hospitals, one of them being our newly constructed medical school, which was built out to become a 1,000-bed hospital, and one of our administrative campuses to become a 2,000-bed hospital. Specifically around digital health, it really energized the organization to make very rapid conversions. So we had done a lot of work under Toby Cosgrove's leadership and Tom Mihalovic's leadership to put in place the platforms needed to do digital health. But like in most healthcare systems, there was relatively slow adoption, either by patients or providers or by clinical leadership. And we all know the reasons for this, of course, which is government regulation and policy, payer barriers, and regulatory problems with state licensure and things like this. What really happened overnight is we converted entirely from about a 98% office-based outpatient practice to a 100% virtual practice. It's impossible to be seen in person at the Cleveland Clinic now on an outpatient basis. Everything is done via virtual visits or telephone, and the virtual visits may leverage Zoom, it may leverage America Well Video, it may leverage other types of video technology. So we went from about 1,000 visits per month in the Neurological Institute virtually to over 3,000 a month in the Neurological Institute. And that was one of the busiest institutes that we had from a virtual visit standpoint. In the primary care area, we were doing about 50 virtual visits a month, and now they're doing over 4,000 visits a month. So if you average that across the Cleveland Clinic enterprise, we had a 7-fold increase in the number of virtual visits, and that's synchronous audio and visual, doesn't even begin to include telephone. The other things that we've seen happen are a very rapid implementation of a COVID remote monitoring program and leveraging of health bots. So triage for suspected COVID patients is routed through our website where patients are asked to work their way through a health bot, and then depending upon the output of that, they'll be asked to either telephone their provider or start a virtual visit on the Cleveland Clinic Express Care Online platform.
Here, let me just interrupt you. If you could just explain what a health pod is.
Health bot? Yeah, so it's really a web-based tool where patients are presented with a series of questions, and then based on the response to those questions and branching logic, they're guided to a series of questions. What the goal is to really be able to risk stratify patients who have suspected a COVID infection and to try to provide them with some guidance. I know we're getting into some touchy areas here, and Jaren's going to chime in here in a second to talk about the regulatory barriers around bots. But fortunately, we've had some lifting of these concerns on a national level, and the bot has been fairly effective at guiding patients to either continuing to do symptomatic management in their home or to call their local physician for advice or the local health department or start a virtual visit with Express Care Online, or in the patients who are in most serious condition, to call the emergency room to see if an emergency room visit is warranted for them. So the other thing that's happened is that there is now becoming initiatives are beginning in the executive leadership at the Cleveland Clinic to actually rethink the go-forward strategy. So we had just gotten done with a 1.5 year long strategy exercise, and I think a substantial portion of that may actually be completely reworked because there clearly is an understanding that virtual is here to stay. The only question is going to be as to what extent. Is it going to continue to be virtually 100% as it is right now, or will it shrink back down to a smaller percentage, say 2 to 5%? And I think my personal opinion on that is it's really going to depend on the amount of regulation that is reinstituted once the emergency declarations are rescinded.
Great, thank you. And I do want to just remind folks, we are eager to take your questions, so if you could type them in at the bottom in the Q&A section, not in the chat box, that would be great. We'll get to as many as we can. And Drew, why don't we turn it over to you? Your thoughts? Yeah,
thanks. It's so incredible to hear what leading health systems like Cleveland Clinic have done in this time. And I think a couple of just notes here. One is, Peter touched on the regulatory piece briefly, and it's amazing to me how a situation like COVID really forces regulators to quickly decide which regulations are helpful and which regulations maybe are standing in the way of some pretty major opportunities to improve patient care and drive things virtually. So I've been excited to see that there's been a lot of movement that hopefully some of it will end up helping to move the industry forward from a technology adoption phase. The second thing that I've really observed is that, in part because of the regulations, but largely just because of the pressing need, we've seen healthcare organizations move to adopt technology in days and weeks that we've all been talking about for years. And, there are certain forward-thinking organizations like Cleveland Clinic who I think were very well positioned to rapidly adopt some new courses of action just because they had already put in place a lot of the procedures necessary to put in place virtual care programs, remote monitoring programs, things like that. whereas other organizations who are maybe a little bit further behind had a lot more ground to cover. And so I think, I know we're going to talk a little bit here about operationalizing these virtual strategies. And I think, Peter, your expertise around that in particular will be valuable. For Validic, it was very early on. In fact, the Monday where we're supposed to all be getting together at HIMSS, we realized that we are in the middle of obviously this healthcare crisis, and what do we do about it? And we had this epiphany that, we are a healthcare technology company in the middle of a healthcare crisis. There's probably an opportunity for us to help. And so we pretty rapidly conceptualized a COVID remote monitoring solution that will bring in data such as temperature, oxygen saturation, as well as if difficulty breathing, coughing, cough severity, and now other things that the CDC has recommended to continually screen for. And that's been really effective and has been rolled out with health systems as well as with large self-insured large employers who have employees on the front lines. So these are, we're deployed at like a grocery store chain, for example, to help employees there make sure that they're safe and healthy. We've had conversations about this being deployed with sheriff's offices. And certainly healthcare workers on the front lines as well. So, there's something that really galvanized our company around helping others in a time of crisis. And, we feel very fortunate that we were able to rapidly create and mobilize and deploy a solution. This is like a from scratch built, purpose-built solution for COVID that we built and launched and, conceptualized it 1 week, launched it the next week, and we're onboarding customers by about 10 days after that. So all within about 2.5 to 3 weeks from conception to launch with customers on board. And it's a solution that we felt very proud to have in the market. And it's been great to see other healthcare technology companies really rally to bring solutions to market in this way, in a time of when everyone's just trying to figure out what's next.
Well, Drew, I think, we should emphasize that because I do think it's important that organizations like Validic and others, I think, are really rising to the challenge here. And they're actually, the solution that you mentioned there and others, this is really going to help bring us out of it. And it's really spurred a lot of innovation. And it's just a really great example, I think. So, we're grateful. I think everybody is. A lot of innovation coming out of this tragedy right now. One thing that you alluded to, Drew, was about the policy changes and reimbursement changes. So I'd love to ask Sharon some of your thoughts on that in terms of the recent policy and reimbursement changes around RPM, remote patient monitoring, and telehealth. We did a whole session on this last week just around reimbursement. I'm just kind of curious, what are your thoughts in terms of remote patient monitoring and telehealth delivery? And do you think that these changes are going to play a role in terms of the future of how care is delivered?
Yeah, you bet. Thank you. So I always like to start off by level setting. It's funny, I've been on a few webinars in the past month, and I keep talking about the same thing, so I hope I don't sound like a broken record. But remote physiologic monitoring and remote patient monitoring, which are two separate types of services that are offered and identified by CMS, actually have been covered and paid by CMS ever since July of 2018, or rather actually November of 2018. July of 2017 is when they proposed it, they being CMS. So it's very important to level set, to let everybody know and make sure they understand that remote patient monitoring as a service has been payable for a few years now. And if anything, remote physiologic monitoring became payable in 2019, and they most recently added another code. And what happened was that for years, CMS, when approached about digital health just generally, would always kind of stick it under the bucket of telehealth and say, yeah, this is all telehealth. And telehealth actually has a bunch of very arduous restrictions to it, which include modality restrictions, where the beneficiary has to present in, which is actually in a health professional shortage area or not in a metro statistical area. It has a stipulation on the originating site. It can't be from a patient's home. For example, the distant site practitioner has to be on, it's one of a few that are listed, and there's a very limited list of telehealth services. So it's important that back in 2018, when CMS formally embraced an existing code, it was CPT code 99091, which was not necessarily a remote patient monitoring code, but they made it to be one. They said very explicitly, look, we're going to cover and pay remote patient monitoring services because these are not considered Medicare telehealth services as defined under Section 1834M of the Social Security Act. And, they're going to be paid for under the same conditions as in-person physician services. So, fast forward, we now have a pandemic and, this public health emergency. And, on January 31st, 2020, AZAR declared the public health emergency. March 13th, President Trump issues an emergency determination under the Stafford Act. And both of those events triggered the emergency grant of authority, allowing AZAR to then institute a number of waivers under separate provisions in Social Security Act, including Section 1135. So within days, CMS moves to expand Medicare telehealth services by issuing what becomes today, I believe, over 66 separate waivers and counting, doing away with every arduous telehealth service restriction imaginable. The one that still remains is, I guess, the modality restriction, but even that, may come falling down once they issue another interim final rule, which was expected last week. I'm assuming that it's going to be coming out this week. And I mean, it's very interesting because doing so is just a sea change for America's healthcare system. We literally went from you need to come into an institution to stay away. We will figure out a way to take care of you and a way to pay providers. I think that in the CMS release, Seema Verma said something to the effect of, this is an unprecedented temporary relaxation in regulation. And I think that's very important to underscore temporary. None of this is in stone. And I think that, CMS moved not just with telehealth. I mean, they instituted the CMS Hospitals Without Walls idea to try to increase hospital capacity through using local ambulatory surgical centers. They gave a nod to rapidly expanding the healthcare workforce by trying to mobilize non-essential medical and surgical private practice clinicians and train staff to be available for temporary employment. The idea of really removing the barriers to physicians and otherwise. Also putting patients over paperwork, temporarily eliminating paperwork requirements, particularly for respiratory-related devices and equipment. All of those are really a big deal. And then in addition to that, of course, the changes that they've done with telehealth and Medicare. Peter says that their telehealth practice, I think I caught this, Peter, you said sevenfold, it's increased. That's amazing. But are we going backwards? And Peter said, I don't think we are. And I agree with everyone, but I'm worried about that because once the secretarial waivers either don't get reauthorized or the public health emergency declaration or the Stafford Act get revoked, it's over. Statutorily, it's over. The question then becomes, how can we ease into what I'm calling the sunset of these wonderful waivers? And I think that's something that, all of us have to work on.
Peter, do you want to comment on that?
Yeah, I agree with Jaren. I'm concerned how much regulation is going to get reinstituted. The relaxation of the regulations has really led to a complete free-for-all, if you will, or freedom to operate, maybe is a better way to state it, in terms of how to care for patients. So an organization like the Cleveland Clinic, where patients come from around the world, and certainly from every state in the U.S., our ability to follow those patients is somewhat limited legally. And there's obviously some ways that we work to do this in a compliant fashion. But there is still some difficulty there. But more importantly, in an organization that thrives on new patients coming to it continuously, and we consider ourselves a national, international healthcare resource, given the licensure barriers that have pre-existed, it is difficult to see new patients virtually prior to an in-person visit or physically being in Ohio, or if we have a license in those states. And we went through great expense and do bear great expense over time, maintaining a large number of physicians with 6+ or 12+ licenses. So clearly, if there is a reversal of freedom to operate, it's going to have some significant consequences for how we're currently practicing in this quick modification and patient access to services moving forward. Patients will be the ones that will definitely pay the price for any kind of backward movement. Right now, they've got historic accessibility to expertise anywhere they want from physicians in the U.S. And physicians have the opportunity for reimbursement for telehealth like they've never had before as well.
Well, if it makes anyone feel better, our conversation with CMS last week, officials, they said there really wasn't a lot of clarity about how or when they would roll these back or what would officially mark the end of the pandemic, and that they were certainly trying to figure out how they could, rather than roll these back completely, figure out how to incorporate some of these moving forward. So they did seem to have a positive response to what I think everybody's seen in the industry as a really a positive move, that these things have been so widely adopted so quickly. So let's hope that CMS sticks with that thinking and doesn't try to roll everything back too quickly, but rather adopt them.
Hey, Jen, one other thing I just want to add here really quick is that, this is directly regulatory from a CMS perspective, but the FCC has recently announced funding for hospitals and health providers to apply for up to $1 million each for financial support toward IT solutions, telecommunication solutions, connected devices that are necessary to support telehealth and remote patient monitoring. And that's a $200 million program. So, they'll fund, 200 or more organizations to support getting these programs spun up, which, is I think a fantastic resource during this time.
Yeah, I think that's a great point. It just feels like there's a real shift in attitude on behalf of that there wasn't before, and I think hopefully that will remain. Drew, one of the things I think that's been so prevalent is we've really been able to see how telehealth and remote patient monitoring can kind of take the pressure off the system a little bit in a positive way. Can you talk a little bit about that and what you see happening there?
Yeah, absolutely. I'll bring it from a technologist. I'm sure Peter's more maybe front lines. I'll say from what we've seen with our clients in healthcare very directly is that COVID-19 has really made already prevalent capacity issues just really awful, and it's really accelerated some issues around provider burnout across the care delivery system. There's been a lot of conversations that we've had with clients that have really accentuated this, and we saw a recent study by Evidation that showed that about a third of previously scheduled inpatient appointments have been canceled. 52% of patients are worried about going back into the healthcare system at all because they're worried that just going to be seen for anything other than COVID will expose them to COVID. And so I think that what that really highlights is that remote care and virtual care is really clearly here now, and I think it'll likely continue to be here for a long period of time as we continue to kind of ebb and flow through COVID until there's in coronavirus until there's a vaccine. But I think what this highlights for me is a couple of things. One is that there are furloughs happening across healthcare, especially in doctors' practices. Who are not necessarily frontline health, hospitals, because they've seen their patient volume drop by 50% or more, and because of the reimbursement codes that Jaren was mentioning, there are opportunities for telehealth and remote patient monitoring services to actually take some of the place of that revenue, which I think is a really big opportunity. And I'd actually point to some of our own data that we have. One of the remote monitoring programs we run with a very large nationally known IDN that has tens of thousands of patients being actively monitored for diabetes and hypertension. 88% of the physicians who have patients enrolled in the program say that the program actually saves them time. 92% of the physicians say that they actually provide better care because of the data that's available through the program. And 58% of the patients in the program say that they feel more accountable to their care. So you can actually have really good healthcare and strong outcomes through these virtual care strategies. And it can actually both pay for time as well as through the RPM reimbursement codes, as well as make the healthcare workers more efficient at a time when it's definitely an overburdened healthcare system that we're sort of seeing come to bear.
Peter, I'm wondering if you can talk a little bit about how do you do this quickly? So out there in the field, from an operations perspective, how do you quickly mobilize to do remote patient monitoring?
Yeah, it's a tough question. We did spend 4 or 5 years building out our technology platform at Cleveland Clinic, and it depends on what your goals are with your technology platform and what you want to do with remote patient monitoring. When we started looking into this 5 years ago at our organization, one of the minimum requirements that our physicians asked for was that the data from a remote patient monitoring program be integrated into our electronic health record. We use Epic, and as many of you know who work with Epic, it is extremely difficult to get data into Epic other than through a keyboard. And to do that kind of work, it does require some development. Fortunately, there are companies out there like Validic that act as the data aggregator. If this is the model you want to go with. There are hundreds of different types of devices that exist in the consumer market. It's nice to be able to use the ones the patients want to use. Many patients already have these devices. Diabetics have their favorite glucometers that they want to use, or the endocrinologists, the primary care doctors have their favorite devices they want to use, or people have their favorite blood pressure cuffs that they trust being more accurate and precise. And by working with a company like Validic, the data can all be sent there and then have the data flow from Validic into the EHR. So your IT teams only have to do that integration work once. And then each time the new devices come onto the market or new vendors come onto the market, you don't need to continue to do that work. We can, as a healthcare system, we can push that work off onto Drew, and that's his problem. And they've been a good partner for us over time. So if that is one of your requirements, is the data comes into the EHR, it's good to have a head start on a program like this. But in the short order, companies that offer remote monitoring tools and platforms like Validic do offer dashboarding solutions as well. And these can be relatively quickly stood up where the data flows from the patient to the dashboard. And then an individual nurse or care coordinator, physician, some other provider, then monitors the data coming in through the dashboard, and it's to log in through a separate website for this, and then correlate that data with what's known about the patient in the EHR. So it's a little bit of a clunky workflow, but it can be done in a quick period of time.
Drew, can you follow up on this a little bit? You've got a lot of different clients out there, and how quickly have you been able to deploy this in different sites and kind of comment on what Peter was just saying there? You've got a lot of patients out there that have their favorite device, their favorite glucometer. Do you start there? What do you do?
Yeah, absolutely. Yeah. So, it really depends on the scope of the program, but I would say the very first thing is don't try to do everything up front, like start with the basics and scale. There are some very, very simple blocking and tackling things that you can do to create, to stand up a remote monitoring program at the outset. I think that EMR, like deep EMR and workflow integration, is absolutely critical to scale a program. And that's really kind of where we started, is our bread and butter of being, an embedded solution. But I also think that if you're truly trying to stand something up now from scratch, the EMR integration side, part of it is probably a 60 to 90 day exercise with both Validic and your IT technology teams working together in collaboration to make sure that those views and workflows are operating in a way that's truly going to work with your organization. So we're working with an organization right now that's looking to stand this up very quickly, and we're doing a very light integration up front. So we're integrating with their single sign-on, and we're integrating with some workflow tools that they have just to route messages around their organization, but it's sort of outside of the EMR to start with. And then just to get up and running, get patients onboarded with glucose meters, with blood pressure monitors, with pulse oximeters, et cetera. And then we work with organizations that provide a lot of device and logistics support, if that's something that's interesting. Like we have connections with organizations that can actually kit the devices and ship them out and have them delivered to patients, which is really important now if a patient doesn't have a particular device. So I would say, there's no one size fits all, but there is an easier way to start. I think one of the things we see with the health systems a lot of times is that a business owner, usually a clinical business owner, has a really simple concept to get started, and then that goes to committee, and then all of a sudden it turns into this really gigantic project where everybody's looking to do everything, and the whole ocean seems to need to be boiled, and it's a very large pot of water with limited amount of resources. And so my recommendation is to keep things very crystal clear and tidy up front. And once you have a strong program in place, for example, working with an organization like Validic, know that you can scale that out repeatedly across the enterprise in a way that's not going to be department agnostic, not going to be specific to any one department or any one type of disease. We're going to be able to go across the enterprise and work with the needs of every part of the organization.
I want to take a moment to get to some of these questions that are coming in. And Jaren, we're getting a lot of questions and inquiries about kind of the difference between telehealth, telemedicine, remote patient monitoring, a virtual check-in. Can you talk a little bit about the differences between those and give us kind of the quick and dirty?
Yeah, it's unfortunately not so quick and dirty. So I started off by saying, I guess the difference between remote patient monitoring and telehealth, the biggest one that I would point out is just the modality. Remember, definitionally, through statute and through regulation, CMS up until the pandemic, had a very rigid view of what was allowable under a telehealth service. And to be a telehealth service, you had all of these arduous restrictions, which include right off the bat, the big one to me is the modality. It has to be live, real-time voice and video. And then, of course, you have the rest of them, which is, the beneficiary has to present in the health professional shortage area or not in a metropolitan statistical area. There's an originating site stipulated by CMS, whether it be a skilled nursing facility, a hospital, et cetera. It can't be, for example, a patient's home. The distant site practitioner had to be a doctor or another stipulated medical professional. Not all of them can bill directly, and that actually curtails the list of those available qualified healthcare professionals. And then, of course, CMS had a very limited list of what telehealth services actually were. So if you think of it that way, when thinking about remote monitoring and why it was such a big deal that they distinguished the two, is that remote monitoring does not necessarily involve live voice or video. Typically, it's passive monitoring that's done through sensors or through medical devices that are used in the home use medical equipment, which then sends the information back into a solution like Drew's, for example, Validic, which can passively monitor, take in that information, help display it, transfer it, store it, convert it from one preset specification to another, and then get it to where it needs to go, to somewhere like Cleveland Clinic, where Dr. Rasmussen can actually, make use of that information. So I think, you have to look at the modality issue as kind of a big deal, because up until the pandemic, that was one of the bigger differences between, these different services. So then as we go on into, okay, well, what is remote monitoring? Then you have, separate codes. Code 99091, for example, is really a physiologic data interpretation and collection code for digitally stored and or transmitted patient health data. So it's not necessarily a remote monitoring code, but when CMS decided to adopt it and cover it and pay it, they actually acknowledged that it's not a remote monitoring code, but that they wanted to make payment separately available as soon as practicable because they saw that these services were really needed. When they actually did finally embrace remote physiologic monitoring, it was through the creation of 3 new codes, which, full disclosure, myself and Peter actually are advisors to the American Medical Association Digital Medical Payment Advisory Group. That is the group that submitted the applications to create these remote physiologic monitoring codes. So, they created these now 4 codes, 2 of which are non-physician work codes. They're really what we call practice expense codes, and then 2 which are physician work codes. Those are very different than the 80 telehealth codes, or rather the body of telehealth codes that recently have been, really affected through the waiver authority that I was speaking about, because it eliminated some of the stuff that I was talking about. For example, an originating site can now be a patient's home. That's a huge deal. When it comes to things like modality, they haven't gotten rid of that, but they have identified that it's an issue. We are expecting through, this forthcoming proposed rule that they may address that, they being CMS. But there are issues on that. What about these audio only calls, for example? Do those qualify as telehealth? Those actually have their own separate payment mechanism because there are 6 codes that were created, 3 evaluation and management codes, and then 3 non-physician practitioner assessment codes that are audio only. But these are, this is getting into kind of the reads that I wanted to avoid, because I typically take over these calls and start blurting out a bunch of codes that people don't want to hear about. So to get back to your question, the differences between modalities or services really lie on the modality, how it's provided. And then, some of them are actually paid. Some of them are payable to only a doctor or a qualified healthcare professional. For example, that's the issue with remote monitoring. Some are not. But through the waiver, or through the waivers that they've instituted, some of these things are being actually taken care of. So, for example, the virtual check-in codes, which you asked about, G2010 and G2012, which are temporary codes, CMS had said that, through these provisions, the waiver provisions, they're considering these communication technology-based services that offer sometimes therapy, thereby allowing private practice occupational therapists or physical therapists and speech language pathologists to be able to bill some of these services. Same thing with the e-visit codes. There are a number of new e-visit codes which are actually patient-initiated, which also allow for a doctor to be able to monitor people remotely. And some of those are payable, again, to physicians and qualified healthcare professionals. There are others that are actually assessment because they're not E&M. E&M can't be billed by, therapists and non-physician practitioners. So this gets very dense very quickly, but there are absolute differences between all the codes. And I just wanted to also say really quickly is that even though the waivers, for the most part, don't really apply to remote physiologic monitoring or the remote patient monitoring codes, there was a very important clarification that came out in the most recent IFC issued by CMS, where they now are allowing remote patient monitoring to be billable for an acute diagnosis as well as a chronic condition. Up until recently, they were considered care management service codes. Therefore, they had to monitor chronic conditions, and you had to have a pre-existing relationship with a provider and get consent, et cetera. So they've actually clarified that. Now, that wasn't through a waiver. That was through CMS just making a policy clarification. However, there are some aspects of remote physiologic monitoring that the waiver does touch upon. For example, the consent and this issue of, when you can actually establish the relationship with a doctor. That's under the waiver authority. Those are some of the things that I'm hoping will, outlive the waivers because they make sense, but we just don't have clarity. Yeah.
Yeah, that's a great point. And I know, Claudia, a bunch of these some of these issues came up last week with CMS, and there was a site, maybe we can put that in the chat box there for people to go to, where they had answered some of these questions online.
There's a dearth of FAQs and other available documents that CMS has really made available. I would actually say I would encourage people, providers and patients, to visit telehealth.hhs.gov. I think that's their new telehealth site. That has links to a broader array of other sites.
So we'll go ahead and put that out through the chat box right now for folks. And then I know we've also got a number of FAQs from last week around audio and different modalities that they answered as well. So we'll get those out as well. I think those are really, really great points you bring up there, Jaren. One of the other questions we're getting, and Drew, I'm wondering if you can jump in here, is around, there's a lot of concern that these smaller practices are really going to face extinction because they're not going to survive the shutdown. They're really behind the curve in terms of adopting remote monitoring and telehealth. They're going to be forced to integrate with big, large health systems. Can you talk a little bit about, for the smaller groups that you work with, do you think some of these groups, can they survive? Is there a way for them to quickly adapt here, or are they going to ultimately be merging in with some of these larger systems?
Yeah, absolutely. So I'll take this from two different perspectives. One is just as a business owner, and second is as a technology service provider in this particular time. So as a business owner, I would say, hopefully there's the opportunity to take advantage of some of the financing through the CARES Act, like the PPP program and things like that, to help get through this proximal time. It's a very difficult situation. We have, like I mentioned earlier, we've spoken with doctors' practices as well as large health systems who've had to furlough frontline healthcare workers, as well as a number of other staff positions that are not clinical workers, just because it's a very difficult, it's putting everyone in a very difficult financial position. What I will say is that I've actually been really encouraged by a couple of things with the remote monitoring codes that Jaren dove into pretty deeply and can go on for days, which is why we love Jaren on this stuff, because no one knows it better. So one of the big things that they did was they said that the RPM codes can be used for acute conditions as well as chronic, and so I think that's a really big opportunity. Where now you can bill for things like COVID monitoring, but also heart failure and other more acute conditions, as well as chronic diseases like diabetes and hypertension and other things. And so what's really interesting here is that, if you have a nurse or a physician on staff, for a nurse to review these codes, half time, they can bring in, $12,000 or so on these codes, depending on sort of where you are in the U.S., based on geographic adjustment. And it's enough where you can actually start to keep a workforce employed by utilizing and billing for these codes, and also helping patients, because the fact of the matter is, for diabetic patients, hypertensive patients, the folks who you're seeing regularly in the healthcare system, they're coming in for quarterly checkups. Well, it's about that time, right? The last time they were probably seen was in January, February, and now it's April, May, and they still need to be seen. They still need to have their numbers shown, and you can't take a video visit and hold up a logbook and ask them to to show it. That's today how some of these conditions are being managed. And the fact of the matter is, there is reimbursement from CMS and other commercial insurers today to help with that. So that would be one of the first places I would look, is how to leverage the technology today to bill for work that can be done.
Great. Peter, there's a question here about bots. And, is there any backlash, I guess, from patients in terms of there being kind of maybe sometimes a slow turnaround time between asking a question, or maybe people really wanting to talk to a human being, or, are you seeing any kind of pushback around that or no? Or if you are, how do you deal with that?
Yeah, so I'm far from an expert on bots, and the only bot we're currently using around COVID-19 deals with that particular issue. And I've used it about a half a dozen times myself. It's very, very quick to respond, and it's very short. If anyone has a short attention span, it's me. And you can work through it relatively quickly. It's very responsive, and it rapidly gets you to an endpoint. You can go through it in about 15 to 30 seconds. So we're not, I mean, is there negative feedback? Possibly. We're not hearing it, but it is quite helpful.
Can you talk at all, Peter, about kind of the ROI that Cleveland Clinic may have seen with their remote patient monitoring program?
Yeah, we've used it in several areas. I will admit it's not at massive scale, but there are some areas where we get ROI for it. And it depends upon what your goal is on the ROI. So first of all, in your ACO population, this is a great place to be using remote patient monitoring in your at-risk population, because it can't possibly be less expensive to manage someone than in their home, and in an asynchronous fashion, because you're dealing with the information when you have the time available. So this is a great place to be working, is in your at-risk populations. The other areas where we use it are where we have particular concerns about patients and their safety, and we don't have a great opportunity to follow up with them closely. So an example of this is in our narcolepsy clinic, where patients, where the sleep experts want to put patients on stimulants, and they're concerned about what that's going to do to the patient's blood pressure. So we'll give them a connected blood pressure cuff and monitor their blood pressure over the next several weeks after the stimulants are started. Another example where we find this to be tremendously valuable is in our bone marrow transplantation population. So the way the program used to work is that after bone marrow transplantation and discharge, you would come into the hematologist's office every day, Monday through Friday, for a blood pressure check and a temperature check. And you can't really imagine a worse environment for a patient who's immunocompromised to go to than is a physician's office or a hospital. So we now give these patients connected thermometers, connected blood pressure cuffs, and we monitor their blood pressure and their temperature remotely. So clearly that's a patient safety concern, that is a patient satisfaction and experience improvement, and more importantly, we're freeing up those office visit slots for advanced practice providers and physicians that would otherwise be seeing these patients back for these simple checks, and they're now available for patients with more serious concerns, which we believe are probably billing out at a higher E&M than these checks coming back in. So a lot of times it just depends upon what's important to you as a provider or your organization, and how you're managing the patient and how you're going to measure the ROI.
Great point.
Yeah, and Jen, I'll just say, without going too deep into the numbers here, I'll just say that Validic has a number of ROI data that we can share. If anyone wants to reach out, hello@validic.com, we can provide some ROI reports on remote care.
Why don't you, after the webinar today, we'll send out a set of links with some of this information. So if you have some of that, we can push that out to folks, because I'm sure people would be interested. Jaron, one of the things people are frustrated about is that, sometimes folks are doing telehealth or telemedicine, but they're slow to incorporate, remote patient monitoring sensors or preventive analytics. Can you why do you think that is?
This is where it gets into the juice of why this is so difficult. If you're a provider, especially a large provider like a Cleveland Clinic, for example, digital health is anything but easy. You've got capital, you've got clinical validity and evidence that you've got to look over. Your organizational acceptance is a big deal. Dedication from the staff. Your infrastructure has to change. You have multi-layered interoperability to deal with. Sophisticated information technology that doesn't always speak to each other. training, technical staffing, technical assistance, precise workflows. I mean, I can literally go on, and I haven't even gotten into legal frameworks, which is, my favorite area. Plus regulatory compliance. I mean, it's hard. This is an arduous thing, but again, we've been faced from one moment to the next. I mean, CMS literally formally announced a few weeks ago that all elective surgeries, non-essential medical and dental procedures had to be delayed, and we're basically encouraging patients to remain at home to preserve hospital resources, as well as trying to limit exposure by healthcare staff and just patients in general. So this is a reason why now more than ever you have to embrace technology, and all those things that I mentioned. They're not going to go away, but there's no other time that you're going to have at least the fluidity and the backing of the nation's largest public insurer to try to help you ease into adopting these technologies. And I don't think we go back. It's very important to say that, the PHE and the Stafford are temporary. The waivers, will disappear. I love that Emily Yoder last week acknowledged that CMS may not have all the policy and regulatory levers to keep them, but that they would like to put some of this, I believe she said, in the fee schedule. That's great. The other part of this is, what about things that are under enforcement discretion? For example, OIG has placed cost sharing under enforcement discretion. That's a huge deal, and that impacts digital health massively. Lots of people can't afford that 20%, and to pay for something that they see as, kind of unconventional, that they're not familiar with, is a hard draw. So, can things that are under enforcement discretion, are those subject to waiver? I mean, some may not, but these are the kinds of things that we're going to all have to grapple with as a society.
Great point. Last question to you, Drew. What is it about remote patient monitoring you think people don't know in terms of implementing the technology or the value of it?
Yeah, that is a really interesting question. What do I think they don't know? One is, I think that it is a lot more straightforward than a lot of people think to implement. So, one of the programs that we are part of, again, it's actually this large nationally known IDN. They have 40,000 patients being actively monitored, really good, really strong clinical results. A1C drops by a point within a month or within 2 months. Hypertension on average within 45 days drops from stage 2 hypertension to a normal range. Really strong clinical results. And it's with very minimal, quote unquote, patient engagement, right? So there's not a engaging patient app with like a cartoon character that's like popping up and reminding people and encouraging them on a day-to-day basis. It's really, there's just a very strong clinical program design up front where the patient understands what their role is, and they also understand how the care provider and care team are going to be reviewing the data when there are exceptions for them to pay attention to. And just by laying out the program up front, patients are really looking for programs like this that they can participate in, where they know that their data matters and that they're going to get help in their journey getting back to better health. And it just makes the whole thing less confusing, which is really exciting for patients. So I would say that's the thing probably most people don't know, is that it can actually be a program that is highly clinically successful and engaging for patients, can actually be at its core a relatively straightforward and simple program.
So it's easier than you think it is.
Yeah. Don't overthink it.
All right. And with that, that's going to be our last question for today. I know we didn't get to everything, but we do have a record of questions, and I'm sure some of our panelists will take the opportunity to get back to you. We are also going to be sending out a list of the resources that Drew and others mentioned today, and Jaren, and that I mentioned, along with a link to the recording. And I want to thank Validic again for supporting the program today, and thank our panelists. Peter, Jaren, we really appreciate you taking some time with us today during this very busy time. So thank you. And thanks to everybody for joining us. Have a wonderful afternoon and stay safe out there.
Thank you.
Thank you, guys.